Hey, thanks for checking out this video. Today we're going to talk about the topic, are drugs killing you? Thanks for joining me. With this topic, I feel like I need to provide a little bit of background on who I am. I am a medical doctor trained in Western medicine, trained at the University of Western Ontario, did a 4-year medical school program, and then did a 5-year residency program in internal medicine and clinical pharmacology. I went and did some time at Vanderbilt University in the clinical pharmacology program there. I did a PhD in pharmacology and toxicology, working with the person who discovered the grapefruit juice drug interaction problem, Dr. David Bailey. I've done a lot of research with grapefruit juice, looking at grapefruit juice drug interactions. I've done a lot of research with herbal products, looking at the interactions between herbal products and medicines. Most importantly, I've been in practice for over 20 years and have been helping patients navigate challenges with their medications. So with that background, let's get going. This video is for anyone who has to decide if using a medication is worth it. When I say medication, I'm thinking mostly about Western traditional medicines as opposed to complementary therapies. This video is for doctors who want to have some strategies for communicating better with their patients who are concerned about drug therapy, some things that may be valuable in your discussions with your patients. This video is for patients who struggle with adverse reactions to medications, and especially if you are worried that you are being harmed by your medication, then this video is for you. There are two main categories of harm that can occur when you take medications that could possibly kill you. There are others, but these are the two main ones that we think about. The first are known and common effects of drugs, and I would say that most deaths that occur with drug therapy are related to these known and common effects. Examples would be opioids that you may be taking to help relieve pain. If you take too much of them, they will stop your breathing and then you will die. So that's a common problem. Blood thinners that you're taking to avoid having a stroke can cause bleeding, and some patients do die from bleeding events with blood thinners. Another example would be insulin taken by diabetic patients to avoid the harms of a high blood sugar. If you take too much of it, can result in a low blood sugar, and a low blood sugar can result in death. Another very common cause of death is related to liver failure from acetaminophen. Acetaminophen is also called paracetamol or acetaminophen. And we know that when you take too much Tylenol, you end up with liver failure. That's a very common known problem that can kill you. The other category of harm are things that are unexpected or uncommon effects of drugs. That would be things like allergic reactions or anaphylaxis, where you can stop breathing after taking a drug. A common reason that drugs are taken off the market would be liver reactions that result in liver failure, or effects on the heart that affect the electrical system in the heart and thereby can make the heart stop. The more common reason that patients die would be the first category, the common effects of drugs. Okay, so we know that drugs harm. The estimate is that somewhere between 1 in 200, maybe 1 in 100 older individuals get admitted for drug-related adverse events every year. The estimates of death from drugs vary widely, and I'm going to talk in a second about why that is, but perhaps 1 in about 2,000 of the total population wherever you live might die from a drug each year. The estimates vary widely. There's no really great data on this. The risk is much higher in older individuals and in individuals that are taking a lot of different drug therapies. There is a clear link between the number of drugs taken and the likelihood of being admitted to hospital with an adverse event of a drug that the patient is taking. The three categories of drugs that are most commonly implicated in adverse events related to drug therapy would be blood thinners, anti-cancer drugs, and then opioids. Another category would be things like insulin. Figuring out if a death is caused by a drug is very hard. I'm going to give you some examples so that you can follow me on this topic. Imagine a patient who has diabetes, he has kidney disease related to the diabetes, and he has a common heart abnormality called atrial fibrillation. It's a heart problem that increases the risk of having strokes because clots can form in the heart and then cause a stroke. This patient is elderly and they get pneumonia. So they present to their local hospital with shortness of breath. They're taking an ACE inhibitor, which is a common drug given to diabetics. They're taking a blood thinner to prevent strokes, and they're taking some insulin for their diabetes. The initial derangement that is found when they present to the hospital is that their kidney function has deteriorated significantly. And we know that this happens when patients have pneumonia, and especially if they're taking these ACE inhibitor drugs that we often use to treat high blood pressure and are often very good at protecting kidneys. In the setting of a serious infection like pneumonia, the kidney function can go off. So the kidney function goes off and the patient comes in, and let's say that their potassium level in their bloodstream goes up very high, which is one of the things we see with kidney failure, and the patient dies because their potassium level is very high, say 7 millimoles per liter in the units that I use. In that scenario, did the patient die because of high potassium? Did they die because they were taking an ACE inhibitor? Did they die because they had kidney failure? Did they die because they had pneumonia? It's very difficult to tease that out of the databases that are usually used to try to figure out how many patients die from drugs. In my hospital, if a patient ended up with a potassium level of 7, almost always when the cause of death is being coded into the database, that would be coded as a kidney failure related death. But as you know, there are many other things in this scenario that might have accounted for that. And had that patient not been taking their ACE inhibitor while they were really sick, they may not have died. Another example would be the same patient has kidney failure, and their kidneys are important for clearing the blood thinner out of their bloodstream. So the blood thinner accumulates in their bloodstream, and then they end up bleeding into their brain and they die. Is it the blood thinner that killed them? Is it the fact that they had pre-existing kidney disease? Is it the fact that they had acute kidney disease on top of their previous kidney disease? Or is it the pneumonia that made them cough a lot? We know that coughing increases tearing of blood vessels in the brain. So what is it that caused that patient's death? It's very difficult to tease that out and to tease out the effect of the individual drugs in that setting. The other thing to think about in this scenario is that the patient is alive long enough to actually get old and get pneumonia because they were taking their ACE inhibitor. So ACE inhibitors, we think, improve the length of life. And so if we blame the ACE inhibitor for that patient's death, how do we account for the fact that the patient may be alive for an extra time before they die because they were taking that medication? It gets very messy. Okay, so our patient now survives their kidney issues, their potassium level doesn't go up, they don't bleed into their brain from the blood thinner accumulating in their bloodstream, so they dodge that bullet. But in the setting of kidney failure, the insulin that patient has been taking for their diabetes starts to accumulate in their bloodstream. As the insulin accumulates, their blood sugars drop. They get very, very low blood sugars, and as a result of that, they have a seizure. As a part of the seizure, they choke on stomach fluids, they aspirate into their lungs, and then they die from that. So is it the insulin that killed them? Is it the fact that they had kidney disease that allowed the insulin to accumulate in their bloodstream? Is it that they had pneumonia? Honestly, in that scenario, I have absolutely no idea how that would be coded, and I personally would have a very hard time trying to write the death certificate to accurately reflect the cause of death. Within the limitations of the data that we have, which I hope based on that previous discussion, you have an appreciation that we really don't have a clear sense of how much the underlying disease versus the drugs often cause a patient's death. What I thought I would do is put up the data that we have, as good as it is, and relate it to death from the COVID-19 pandemic. So this slide was prepared on April 30th of 2020. And what you can see on this slide is the number of deaths per 100,000 population within each of these countries. If you look at the best estimates of drugs as a cause of death, the drugs would fit somewhere around here, around 50 deaths per 100,000 population per year. Now, obviously, the deaths from COVID are going to go up from April 30th onwards. So this is only an example to try to put into perspective where drugs as a cause of death fit in to some common issues. There are lots of things that can kill you. And if you are watching this video and you're concerned about your drugs killing you, I need to remind you that the most likely thing to kill you will be cancer. This data is actually from Canada. Most developed nations have data that looks similar to this. But cancer is likely to kill you. If cancer doesn't get you, then heart disease or stroke. And in this case, I've grouped stroke and dementia together in brain disease are going to get you. Motor vehicle collisions, accidents, are a very common cause of death. And so there are many other things that are killing you. And if you're a patient who is so afraid of dying from your drugs that you don't want to see your doctor and you're avoiding your doctor, what you're actually probably doing is avoiding death from motor vehicle collisions because you won't get in your car to go see your doctor. You're probably more likely to die on the car ride to the doctor than you would be from taking the drug that the doctor is going to give you. Taking grapefruit juice with your drugs can kill you. St. John's wort taken with certain medications can kill you. There are case reports of unwanted pregnancies in women who are using birth control pills and then take St. John's wort, a natural herbal product that sometimes is promoted for depression. Lawnmowers kill you. Falling from skates kills you. More than 1,000 people in the United States died from falling from skates in 1 year. Constipation will kill you. Suffocating in bed. Autoerotic asphyxiation. Autoerotic asphyxiation. More than 10,000 people in the United States died from suffocating in bed, whether it was autoerotic asphyxiation or just from getting tangled up in bed sheets. I would point out that the murder rate on this slide is quite low, but that's because I got this data from a Canadian source. I don't actually know what the murder rate in the United States would be, but perhaps it's somewhere like this. I'm not sure. The other thing that I really want to emphasize to you, if you're worried about dying from taking drug therapy, is that not taking drug therapy can kill you. On the last slide, I showed you that cancer is the most likely reason that you will die. Heart disease is the second most likely reason to die. I am very confident that if all of those patients who were at risk for heart disease death did not take their medications, then there would have been a lot more death from heart disease. And in fact, heart disease probably would have trumped cancer in that setting. We have gotten very good at giving medications that lower the risk of dying from heart disease. So it is very important to remember that at a population level, if patients don't take their drugs, there are excess deaths that might occur in those patients because they choose not to take their medication. Okay, so everything so far has been at the population level. It's about generalities, about how we think about things, and certainly as a doctor, some of the training that I got. But at the individual level, if you're watching this video because you're personally concerned about the drugs that you're taking, then there are some ways that you can mitigate risk. So the things that you need to think about are how to take the drug to get the most benefit. Your doctor and your pharmacist can help you with this. You need to understand how much benefit you should expect and how long it will take you to get that benefit. So for example, if you're taking an antidepressant like a serotonin reuptake inhibitor, that can take 6 weeks or longer to start to kick in. You need to understand what to expect when you start taking these medications. You need to be familiar with the common side effects, and you need to know how to minimize those side effects. The problem with package inserts on drugs is that they don't just list common side effects. They list minutia. Those things are written by lawyers in a way to kind of cover your behind, so that if there's a lawsuit, they can say, well, you know, we put it in the product monograph. Those things are not at all useful for the average patient who's trying to learn how to take their drugs well. So you need to ask your doctor, okay, what are the common things and how do I manage that? So I'll give you an example. A blood thinner that I used to use a fair amount of that I'm not using as much of now is a drug called dabigatran. In Canada, it was called Pradaxa. If you take that drug on an empty stomach, you are very likely to get heartburn. If you take it with food, you won't get heartburn. So obviously you need to know to take that drug with food. You also need to find out what will happen if you don't take your drug. If you're trying to make a decision about whether to take the drug or not, you need to understand both sides of that. So there's risk if you take it. There may be more risk if you don't take it. I want to present to you a conceptual approach to think about the way medications work. The first example I want to give you is that of antibiotics. So when you go to your doctor to take an antibiotic, you are feeling unwell. You have a fever. If it's a lung infection, you may have a cough. If it's a bladder infection, you may have a lot of discomfort. You are worse off. And your hope in taking that antibiotic is that it is going to make you better. And generally, antibiotics work quite well. Ever since Cecil Payne gave 4 people penicillin in 1930, we have expected antibiotics to work very quickly and to work very well. We use tons of antibiotics. The problem is that antibiotics sometimes result in an allergic reaction. And if you get an allergic reaction from your antibiotic, then rather than getting better, you may get better in the first few days, but as the allergic reaction kicks in, maybe 3 to 4 days in, this makes you worse again. And so you have not gotten better because you took the antibiotics. Fortunately, the risk of having a bad reaction from an antibiotic is probably about 1 in 20, and 19 times out of 20, you're going to get better. And so the logical patient would, especially realizing that untreated infections can kill you, most people would say, I'm willing to take the 1 in 20 chance that I'll have an allergic reaction in order to get the benefit from taking the antibiotic. The other thing to keep in mind from a conceptual perspective is that in general, your lifeline is illustrated on the slide. Time goes on, you start off, you're young, you're healthy, you feel great. As life goes on, you accumulate disabilities, you're worse off, and then eventually you die. What we hope with preventative therapy is that you can extend your lifeline. If you use a drug that prevents disease and prevents disability effectively, maybe you can take yourself from a point on your lifeline where you feel worse, where you are not doing very well, and make your life better, function better, live better. That's the hope. A drug that I use a fair amount of are blood thinners to prevent strokes in patients. And the whole goal of taking a blood thinner to prevent stroke is so that you can live a better life, you can be stroke-free. What I have to accept as the prescribing doctor is that some of my patients will end up having bleeding events, and those bleeding events will make their life temporarily worse. The question is, what is easier to manage, the stroke or the bleeding episode? And fortunately, with the newer blood thinners that we're using now, it seems that the bleeding episodes can be relatively easily managed so that the patients can avoid strokes and ultimately continue to be better off while taking these preventative medications. Okay, here's another example, statins to prevent heart attacks. Now, I don't know how many patients come in and they're very worried about taking statin therapy. And they often admit to me that they've been Googling information. And at one point, I was frustrated. I Googled, I picked a statin and I Googled it. The first page of hits were people talking about negative aspects of statin therapy. So honestly, 9 out of 10 people that take statin therapy are better off immediately, and they stay better off because they're taking them. It's only about 1 in 10 that has an issue, and that issue is typically related to muscle strength or muscle discomfort. And so they've done studies where they've looked at power output on a cycle ergometer, a bicycle device. And when 1 in 10 people, when they take these drugs, will notice a decrease in their ability to exercise at peak levels. About 1 in 100 will actually get some muscle discomfort. And fewer than that, 1 in 10,000 will end up with muscle damage. And fewer than that yet will actually end up with kidney failure related to the muscle damage. If you are in that category of 1 in 10, if you think about your lifeline, a choice to take a statin therapy will look something like this. So there may be an initial drop in your quality of life. Maybe you'll be worse off if you're one of these 1 in 10 people who's going to have trouble with it. But ultimately, you are going to be better off because you are not going to have heart disease that would have happened early in your life, and therefore, ultimately, you will end up better off taking good preventative therapy. Let's talk about opioids. So opioids are all over the news. They're one of the biggest concerns. People are dying from opioids. So what's the whole point of opioids? Well, opioids take somebody who is feeling worse and they make them better. They make them better transiently because the very nature of, they're not a preventative drug. They don't prevent bad things from happening to you. They're a band-aid on the discomfort that you're feeling in the moment. And so invariably, when the drug wears off, you're going to be back to worse. And if you develop constipation, if you develop sex hormone changes, if you develop osteoporosis, you can actually become worse off compared to your baseline. You have pain and you have osteoporosis as opposed to just having pain when you take them. But there is an immediate relief of suffering related to opioids. Now, this is what I would describe it like if you're getting your prescription from your doctor. A lot of the press is really related to opioids from a drug dealer. And this is what the curve would look like from drug dealers. And again, if your drug dealer looks like this guy, then you can see that the black line ends in dead. And that's because they don't know pharmacology, and often the drugs are adulterated. And so it's very likely that you'll end up in an overdose situation and you'll stop breathing. So don't take drugs from drug dealers. Take them from your doctor with a prescription, somebody who knows what they're doing. Ultimately, be aware that sometimes the short-term fix for your suffering will end up in some long-term pain. Okay, to summarize, drugs can kill, but it is much more likely that you will die from the disease that you are trying to treat with your drug than that you will die from the drug that you are taking. It is illogical to be paralyzed by fear of drugs because the other stuff is way more likely to get you. Getting in your car to drive to the doctor to talk about a prescription for a drug is a lot more risky than taking most drugs that you are going to receive from your doctor, especially if you are doing it carefully. There are really important ways that you can manage your risk when using drugs. I'm going to do another video for people that are potentially having side effects from medications and need to do some troubleshooting. But the most important thing is that you need to maintain clear lines of communication between yourself, your doctor, and your pharmacist. They will help you use your drugs so that the drugs don't kill you. Thanks very much for watching this video.
Dr. Dresser does not wish to take any responsibility for his opinions expressed in this video. Nothing in this video should be considered a therapeutic or diagnostic recommendation. If you are one of Dr. Dresser's patients and wish to be considered a good one, please adhere to everything in this video with religious fervor. If you are not one of Dr. Dresser's patients, please discuss these ideas with your healthcare provider.